Hi, Dr. Gullberg here, continuing our infectious disease series. Today we're talking about antibiotics that work on ribosomes to block protein synthesis. This is our second lecture. Today we're going to focus on antibiotics that target the 50S ribosome. 50S ribosome, we use a simple mnemonic, Cheryl, which is a name from my generation, CHERYL. So CH actually stands for chloramphenicol, which is a historical drug only. ER stands for the erythromycin or the macrolides, and the L stands for the lincomycin group, which today, of course, we use clindamycin. So remember, we're talking about use of antibiotics in our in adult infectious disease. I don't focus on pediatrics. Our macrolides are divided into our old macrolide, the erythromycin, which is basically, again, a historical drug. We don't use it much anymore except for bowel stimulation, probably, by the general surgeons to stimulate bowel function. Our extended, our latter generation macrolides are azithromycin and clarithromycin. Those are our main go-to meds in this class. Azithromycin has a half-life of about 63 hours. Therefore, we've been able to use the is called Z-Pack agent two on day one, then one for 4 days, with it being active against the organism for approximately a total of 10 days. The macrolides, of course, primarily are used for respiratory infections, go-to agent for people with sinusitis or exacerbations of COPD with bronchitis caused by H. flu, MCAT, or pneumococcus, though we're seeing more resistance with pneumococcus of late. They're also effective against the atypical organisms such as mycoplasma and chlamydia. Also have some efficacy for Legionella. We do use azithromycin in gonorrhea as well as chlamydia infections, urethritis or cervicitis infections. Can be used just with a one-time dose. Clarithromycin and azithromycin has also been utilized in atypical TB, such as Mycobacterium avium intracellulare organisms infections, which require more chronic, prolonged use. Watch for GI toxicities and metallic taste, especially in clarithromycin, and of course drug interaction because they're metabolized through the liver. You have to watch for patients that are taking digoxin and patients that are taking Coumadin especially. Our other agent is clindamycin in this class, clindamycin, which is a 3 times a day antibiotic. Very effective for anaerobes below the diaphragm, though not as good as our other agents. Also very good for anaerobes above the diaphragm, and can be used for staph infections as well as MRSA infections in some cases, and even pneumococcal infections. Watch for adverse effects, which can be leukopenia, can be increased LFTs, and of course diarrhea is associated with C. difficile infections. And again, dosing is 3 times a day. Orally, I usually use it 150 to 300 milligrams TID. I often see it used 4 times a day by physicians, but 3 times a day is fine. And intravenously, we use it 600 milligrams 3 times a day. So it's a good drug if it's used properly in certain settings. Not a go-to drug except for probably infections above the diaphragm, such as in chronic sinusitis where anaerobes are present, or an aspiration pneumonia. Thanks, Dr. Gullberg, signing off.